Ladies and gentlemen, dear friends and colleagues, welcome to the wrap-up of the Thoraxcenter of the AHA 2021. My name is Nicolas from Mieghem from the Erasmus University Medical Center in Rotterdam, and as always I'm happy and pleased to present the wrap-up together with my good friend and colleague Joost Daemen. As you notice, we are a little bit late with our wrap-up, but COVID interfered with the recordings, but here it is anyway. So let's quickly start with one of the randomized trials that was quite appealing to me. That was the AVATAR trial. This was a trial evaluating patients with asymptomatic severe aortic stenosis, and basically it's the second of its kind, because we had a recovery trial that was published in the New England Journal from our Korean colleagues a year or two ago. That was a small trial, 145 patients. In AVATAR they do a little bit better, 157 patients, so still like small sample trials, but it is a randomized controlled trial, and the difference with recovery is that all the patients had to have a negative exercise test before they could be eligible for AVATAR, and that's a big difference with the Korean trial. But that said, I think the results and the conclusions are more or less the same. Early treatment of asymptomatic severe aortic stenosis, probably in selected patients, is definitely worthwhile, because in AVATAR there were numerically fewer deaths. In the early treatment arm there was also only 3 versus 6 cases of sudden cardiac death, and also of interest, in the control arm, 25 of around 80 patients who were in the control arm eventually received a surgical aortic valve replacement. What I think was of interest was that more than 50% of the patients still received a mechanical valve. And we're talking about a mean age of 67 years old. I think we more and more see a trend towards a preference for bioprosthesis, even in patients of 60 years and above. So I think it is a little bit different from our current practice, and also, of course, there was no TAVI involved in this trial. So my takeaway is, of course, we need to consider an early treatment of asymptomatic severe aortic stenosis, but I believe it's in this day and age essential to also include TAVI as a treatment option, also in patients with asymptomatic severe AS, and that is, of course, where the early TAVR trial comes in. That trial is expected, at least the results and the presentation of the results is expected in the summer of 2022, highly anticipated, and this is really a trial of another dimension. More than 1,000 patients will be randomized to either early treatment with a TAVR or watchful waiting approach. Yeah. Any comments there, Joost?
No,
what do you
I fully agree, and to me I think this is again a nice eye-opener about the fact that severe aortic stenosis, even though it is asymptomatic, is not a benign entity. I mean, the risk of death and my repeat hospitalization for heart failure was 33% within a couple of years in these patients. So that is significant, and that was in this trial reduced by over 50% by doing a early aortic valve replacement. So I think that attests to the concept, and I also pretty much look forward to the results of the early TAVR trial.
There was another interesting trial, and that was not a randomized study, it was more a prospective registry from the Cleveland Clinic, where they looked at the effects of myectomy in patients with hypertrophic cardiomyopathy. And specifically they were focusing on changes in quality of life. A relatively small sample size, 136 patients, but the results were quite impressive in terms of improvements in quality of life. And I think we already in our preview said, well, we expect quite a significant benefit, and that turned out to be the case. 92% of the patients had improvement in quality of life, and 80% had a big improvement, so more than 20 points in the KCCQ evaluation testing. So that is quite significant, and I don't think everybody argues that patients with symptomatic hypertrophic cardiomyopathy and a thickened basal septum, they do need some kind of treatment. Unfortunately, in this trial, there was only a surgical option. Also here, we have, I think, a very good percutaneous treatment, which is, of course, alcohol septal ablation therapy. And I think one of the next frontiers will be, hopefully, a randomized study comparing surgical versus catheter-based myectomy or hypertrophic cardiomyopathy treatment.
Yep, absolutely. The therapy works. I think that is becoming more and more clear now. I also think the therapy is still vastly underused.
The surgery, you mean?
surgery, but also I think the concept in generally. But yeah, of course, I mean, we're doing more septal ablations nowadays, but it's still, I think, I wonder whether we could expand.
And it's more centralized, I think.
Yeah.
This is one of the treatments that is still centralized, and that is not a bad thing per se. I think you do need to have heart team centers of excellence to specifically focus on certain techniques. And from a surgical point of view, I heard that this myectomy treatment is not too big of a deal, but at the same time, if you don't do an appropriate volume, it becomes difficult to become.
Exactly, it's a very heterogeneous disease with a lot of components in the way the muscular part is anatomically functioning in these patients, involvement of the mitral valve apparatus. So it's not a simple thing, and I definitely agree that it makes sense to centralize.
Yeah. Another interesting study related to surgery, related to CABG, but then, what to do with pharmacotherapy in patients with ACS?
Absolutely. So this is something we all recognize. You have this patient coming in with a non-STEMI, preloaded with ticagrelor, and oops, you find severe three-vessel disease, left main in a patient that is still operable, and you consider this stable patient eligible for surgery. So you go to your surgical colleagues and say, okay, well, we would propose to have this patient operated. I say, yes, okay, but then, oops, the patient is on ticagrelor, what should you do? Do you treat him or her directly? And most surgeons nowadays still say, oh, no, patient is on ticagrelor, high bleeding risk, we don't do that. Or you postpone for another 5 to 6 days, posing the patient at risk for future ischemic events during the hospital stay, infections, etc. And now there is this nice titrate CABG trial, which is the first randomized controlled trial from Canada to address this issue. So 143 patients, one-to-one randomized to either a early surgical approach, meaning up to 3 days, or a prolonged or a, let's say, postponed surgical approach with surgery after 5 days, in line with the current guidelines in Europe stating that you need to wait for 3 days. In the US now it's still 5 days, but in this trial patients were nicely randomized, and what turned out, there is no penalty in terms of bleeding complications if you do your surgery at 2 to 3 days versus 5 to 6 days. And that, I think, is a important finding that will have clinical implications, keeping patients shorter in the hospital up until the time of surgery, and leaving beds to patients which potentially need medical treatment as well in this COVID area with a shortness of bed capacity, etc.
At the same time, I think this is quite a conservative handling of the surgeons, right? Yeah. They immediately say, okay, we wait for 5 days and then we will consider an operation. It demands a paradigm shift and a change of mindset with our surgical colleagues, and I hope that they will follow, because this is a smaller study, we have to agree with that, but at the same time, with these kind of concept trials, you don't need a lot of patients to prove the point, right?
Absolutely, and even in this trial, in the patients that were postponed, 1 out of 10 patients had to undergo either surgery or percutaneous treatment before the planned surgery date, simply because of the fact they had new ischemic events. So that it's not benign to keep patients waiting for 5-6 days.
But it would be nice if you could also neutralize the ticagrelor effect.
Absolutely, and that brings us directly to the next trial we wanted to discuss, and that was the REVERSE-IT trial. So REVERSE-IT was a multi-center open label trial assessing the efficacy of bentrazimab, which is a direct platelet inhibiting agent reversing ticagrelor. It's an interesting concept which was studied in REVERSE-IT trial, and now at AHA the investigators presented the interim analysis on the first 150 patients that were enrolled in Europe, US and Asia, demonstrating that they could successfully reverse ticagrelor action in all of the patients within 4 hours. Plus, very interestingly, there was no rebound activity found if you did your platelet function testing up to 72 hours. So that provides us with a drug that is currently not commercially available in Europe, neither in the US. So that is a potential downside at this point in time. But it is a very promising agent that perhaps makes the use of ticagrelor even more appealing in an era where the drug is now also approved for treatment of stroke prevention and secondary prevention of cardiovascular events next to patients with ACS. So to me, promising drug that might have a role in the near future.
I agree. I think it addresses an unmet clinical need because we always need to balance this, the risk of bleeding with the risk of thromboembolic events. At the same time, there is a word of caution. I think if you're still early or close in time in an ACS patient and you would reverse your ticagrelor, I might, I wouldn't be surprised if you would start to see some stent thrombosis or those kind of events. And I think this trial was just too small and the data were just too preliminary to rule that out.
No, in this trial, no thrombotic events were noticed. I think that is remarkable. But conversely, it's also important to state that I dare to say that virtually none of these patients had a recent PCI. There were either patients that had to stop because of the fact that they had to undergo surgery, or patients that came in with major or massive bleedings, which forced the physician to stop ticagrelor. But that was, I think, only in 3 to 5% of the study.
Interesting, but I do think that the application, the adoption of these kind of strategies, you can imagine the setting that a patient would require semi-urgent or urgent surgery, that you would use it. And of course, patients who are actively bleeding, because we do treat vulnerable patients who are at high bleeding risk. So from time to time, you will encounter these clinically challenging bleeding events. So that's definitely a good, good move. All right.
From drugs to cacao.
Yes, so I was really looking forward to the Cosmos trial. Really had woke up early just to witness the live presentation, and then I found out that the presentation was retracted, so they did not present the data. So we'll have to wait for a later meeting on that. But we will discuss one more study, and that is a meta-analysis of Dr. Sabatine from the Brighams, who discussed CABG versus PCI in patients with left main stem disease. And that is, of course, a hot topic these days in the surgical and interventional cardiology community. There was a lot of fuss around the 5-year presentation of Excel, and then all the polarizing comments that we saw. I don't think there is a reason to polarize, and I think the investigators here did an excellent job doing a patient-level meta-analysis of very high-quality research that was published also in The Lancet, where they ended up with more than 4,000 patients with left main randomized to surgery or PCI. And then it turns out that at 5 years, all-cause death rate is maybe a little bit higher with PCI, but I think it was 11.2% versus 10.2%, so an excess of all-cause mortality, not cardiovascular mortality, but all-cause mortality of 0.2% per year, probably clinically irrelevant. And of course, we see more early infarcts with surgery, but then more spontaneous infarcts with PCI. And then there is also this clear signal of more neurological events after surgery than after PCI. So I do think that one of the conclusions is that you just need to adopt shared decision making. You need to inform your patient as a cardiologist, as a surgeon, share the evidence, and then also the voice of the patient matters.
Absolutely. And I think this study again attests to the fact that all patients with left main disease, PCI is an alternative. And I think it's a very appropriate alternative in a large set of patients.
Yeah, I hope this will settle the dust now after the Excel discussions. So with that, I think we wrap up of the AHA 2021 a little bit later than expected, but hey, here we are. I wish you all the very best for 2022, and we will continue with our previews and wrap-ups of the important cardiology meetings in the years to come. Thank you, Joost, and I thank you for watching.
Thank you. Bye-bye.
Bye.